It always has that effect of feeling like I'm at my funeral, you know, hearing someone go through this is your life. Thank you so much for coming. I wanted to thank Melinda to make all of this possible. She's on the list of accomplishments. The one thing that was left off is I'm a member of the Melinda Smith fan club, and she's been a leader of our Project Restore, which I will tell you about in just a minute. So that's why she's not just Vanna White. She's actually going to be telling you about what it is that she does as the, one of the chief development people on our Project Restore. So just to let you know, we have a mixed audience here, as I understand. So we have students, and by the way, if you didn't sign in, we're going to be raffling off a free admissions to Hopkins Medicine. If you want to just sign up, well, it's actually too late. I think Amy's got the sign up. So, and then we have welcoming people from the community come hear about what the work is we're doing at Johns Hopkins. Yes. So, that was not a hard thing at all to give 2 talks in one and integrate everything together. So, if I bore half of you half of the time but make half of you really interested the other half, then I've accomplished my job. But if you have any questions, please let me know, because I'm happy to have a discussion here. So I do have to give a disclosure, which is I am the inventor of this Mood 24/7, which there's the patent. I'm required by law to actually give that. Oh right, what I add, Cody here came and spent a couple summers with me. He's using it for something, but I don't think it's going to have any long-term side effects, whatever the study is that he's doing using it. But I will tell you, if you want to, invent something that can help you as a clinician to take care of patients, then think about what's not out there. If you sort of come across an obvious thing like, why can't I have my patients just texted once a day to find out how their mood is or how their sleep is or what have you, then if it doesn't exist, go make it happen. That's easy, but I will tell you, if you do it and you make it free, you're not going to earn any money. So I'll just tell you that ahead of time. But for clinical purposes, it's a great tool. So what is multiple sclerosis and transverse myelitis? So Project Restore, I'm going to tell you about Project Restore. Project Restore is sort of the umbrella organization at Hopkins that oversees the Transverse Myelitis and Multiple Sclerosis Center. And I think I've got a pointer here. I'm probably covering the laser. Oh, it's a teeny little laser actually. So so basically the immune system gets fooled in both of these conditions. Normally it should be fighting off bacteria and viruses and fungus that gets across the barriers of the body and into the bloodstream or into the central nervous system in this case. And the immune system gets fooled in part because of genetic predisposition. We know that identical twins, for instance, share a 30% chance. If one identical twin has it, the other identical twin has a 30% chance. But that means 70% is not genetic. And that we know, there's predispositions because of immune overactivation, and then the environment plays an important role. Again, viruses that look like the insulation on the nerve. So each nerve is like a wire, has a wire coming out of it. That's the axon, and each axon is wrapped by myelin, which is this fatty-like substance that is sort of like the rubber that wraps around wires, and it basically gets damaged, and that ultimately leads to problems with conduction along that wire, and over time that wire, if you strip the insulation off the wire that goes right along here in the room, eventually it's going to rust and then break. So that's sort of what happens, and multiple sclerosis can affect anywhere in the brain and spinal cord and the nerve that connects to the eye, so it can have essentially any set of symptoms. Transverse myelitis, transverse means across, myelitis means inflammation of the spinal cord. So transverse myelitis is just sort of like MS of the spine, where you usually get just a single attack, although you can have multiple attacks. And because these are things that affect young people, the average age of onset is 20 to 40 years old, although we've seen kids as young as 6 and people in their 80s with new onset of these, which is sort of cruel that it can be so young. And particularly with TM, TM can affect several month-old children as well. And so the effects are to cause whatever that part of the brain or spinal cord controlled. So that can cause weakness, and people sometimes drag a leg or have a hard time lifting their arm. It can cause pain if those nerve fibers get crossed, or numbness or weakness, or sort of the tingly feeling, when you lay on your arm and it sort of has that anesthesia-like tingly feeling. And then it affects basically any general function that the nervous system is involved in, like bowel and bladder and sexual function. So any of those are the common things. What I tend to study is, it turns out that a lot of people forget that the brain does a lot of things, and among them helps us learn and concentrate and focus. Sort of one of the important things the brain does. You'd think that wouldn't be forgotten, but that actually was forgotten for over 150 years in the case of MS, because Charcot, the father of MS, said this is something that causes cognitive impairment. But it wasn't until really and that was back in the 17th century. It wasn't until the last 10 or 20 years that people really began to understand that it also causes depression as well. So, my sort of entry into this is that I'm a neuroscientist and now a neuroimmunologist working on how the wiring of the brain affects things like concentration, learning, and mood. And so if you sort of take a look at where things are with respect to these illnesses, these are disorders where the immune system is activated and injures the nervous system in this sort of aggressive presentation. Initially, it's just an attack, sort of like an attack. When you get pneumonia, it's sort of, there's a place where all the immune systems run in and creates this fuzzy part on the chest X-ray where all those immune cells are rushing in. Well, this is sort of like that, but in the central nervous system, where those cells rush in and they cause this enhancing effect. Just like when you burn yourself, you get a blister because all the blood cells rush out of the bloodstream and then they cause that blister. Similarly, when there's a breakdown and inflammation in the brain, those white blood cells go into the brain, and that leakiness where they go in causes this enhancement, it's called. And I must have hit the back button. So there's the aggressive part, and we're pretty good at calming down the immune system. There's steroids that are good for anything that activates the immune system, whether it's, if you get poison ivy or what have you. And then we have a host. Before 1993, we had 0 medicines approved for MS. Now we have essentially 9 FDA-approved treatments for MS, and more on the way. So it's actually, you don't want any of these diseases, but this is the best time in history in some ways to have it, because there are treatments now that are available for them that we didn't have before. However, there's a huge need still, because we're good at stopping the inflammation. That's the stripping of the insulation off of the wires. But the problem is that rusting that takes place that I sort of talked about, that once that sort of gets going from the early attacks, about 30 to 60% of patients with conventional treatments will then have a slow, progressive loss of function that it has nothing to do with inflammation. It's more this rusting process. It's sort of, I'm speaking in metaphors, it's not really rust in the brain, but it's this slow process that causes injury to the nerves, and we don't have neuroprotective strategies yet to prevent that from happening. So there also are no treatments currently to restore lost function. Now, we're working on them, stem cells, and I'll tell you about some of the work we're doing at Hopkins along those lines. But there's still a huge need for treatments for these diseases. So let me tell you about Project Restore and sort of what it's about. And that's going to tell you something about where our country is nowadays. So I've had the privilege of talking to many of you. It's been actually a lovely day. And thank you, Kristen and Kyle, for making it a lovely day. I've just been absolutely blown away by the questions that the student body has asked. They're fascinatingly interesting, bright questions. I love that people here have this perspective. 72% of people, I'm told, go travel all over the world and then come back to this beautiful little heaven on earth with all the fountains, and they swear that they don't dye the grass green, I'm told, but it's still green here in the wee months of end of winter. But so let me tell you something about Project Restore. So at Hopkins, this is sort of the Hopkins philosophy, and you have to understand the Hopkins philosophy because it goes back to the origins, 150 years or so, to the origins of what the Johns Hopkins, the founding benefactor, did. He created, so you'll see this triangle on all the lapels of people, and this is sort of the badge with the dome. By the way, you notice the dome is round, and it used to be that patients were seen there in this building, and so the term rounding or grand rounds, that comes from this, because you have to walk in a circle to get around round. So it's got a rich tradition, but it was built on the idea of patient care. I mean, ultimately, our responsibility is to take care of people. And that's what Johns Hopkins, he was a very successful businessman, and he wanted to give back for his success in the world, take some of his good luck and good fortune and hard work and give back to create an environment where he could really help people who had confronted illness. But in order to do that, I sort of think of it as this is what keeps the rain off. What allows us to keep working at Hopkins is the fact that we, number one, teach and do research, which means we're training the next generation, so we'll still be there to do the clinical care. And we also do research, which lets us try to come up with new ways of improving the kind of care that we can deliver. So that's sort of the central mission. And being the triple threat at Hopkins is also one of the things that is unique about Project Restore, which is, as Melinda can tell you, every one of the members of the faculty there, myself, Peter Calabrese, the head of the MS Center, Carlos Pardo, the head of the Transverse Myelitis Center, and all of the rest of the faculty, all are the triple threat. We all see patients, and seeing patients is critical because it helps us to understand what it is that people with these illnesses need, what it is they don't have, and what it is we need to be focusing on. And we also do research and teach. And so that's sort of at the core of Project Restore. So what's the vision of Project Restore? Well, the vision is really that, again, in keeping with the triple threat, the idea is that we provide patient care, and the ultimate goal is to do that four-letter word, right? It is sort of a dirty word to use because cure is a hard thing to even define. So for instance, it may seem really simple to define cure, but if we make it so that someone with MS has no attacks for the rest of their life, but their immune system is still poised to attack, it just can't get access to do the attack, is that a cure? I mean, if someone doesn't have symptoms, but they stop taking a drug and then they get symptoms, sort of defining a cure can be a tough thing. But the goal is ultimately, obviously, to cure disease and restore function. And that's the ultimate goal. We also want to be able to help those who are diagnosed with TM and MS to restore their function, the functions that have been lost due to the injury and the long-term effects of the injury. Research, we want to improve the ability to diagnose. TM, by the way, it often happens in young people, and more often than not, people show up and they can't walk. They're young, Cody Unser, for instance, who's Al Unser Jr.'s daughter. It's the winningest Indianapolis 500 family. Her father won, her grandfather won twice, her uncle won twice. So it's quite a big Indianapolis Indy 500 family. At the age of 12, she was playing basketball and fell to the ground because her spinal cord was attacked by her immune system. And she, is waiting on some restorative therapy, but essentially, the issue with her is that she went to the emergency room and they said, well, your parents were divorced a year ago. You're probably this is just some conflict you're having in your head about, trying to adapt to that thing that happened a year ago. So she was sent home and almost died because it kept getting higher and higher. And if it gets high enough on the spinal cord, one of the things the spinal cord controls, if you get high enough, is the diaphragm, which controls breathing. So, helping people to understand these illnesses and be able to diagnose them early. I just had the privilege of talking to a gentleman beforehand who's had a really good outcome, but in part because his disease came on so quickly, he got treated immediately. And so I think that and the combination of him working really hard on his own rehabilitation made a big difference. So and then teaching. We want to understand MS and ultimately be able to prevent and delay the onset of this illness. We now know that low vitamin D is a risk factor for this. Low testosterone, believe it or not, is a risk factor for this. So this is something that we're beginning to understand better, so the risk factors for these. We want to prevent the onset in those who are at risk, and we want to, again, help establish a model for how to treat these kinds of conditions and go forward. And by the way, I'm presenting, I should have said this, first what Project Restore is, and then I'm going to sort of show you in action what some of the research is that we've done and catch you up on some of the latest findings that we've had out of the Project Restore Center. So what does Restore stand for? Well, it stands for Recover, Stop, and Regenerate. That's the RE in Restore, ST in the middle, SCO actually it should be, oops, and then RE in Regenerate. See, I'm awake now, I wasn't. So recover, stop, and regenerate. So it's recover function after an acute attack, stop both the inflammation and then the progression of disability, the rusting over time, and then regenerate. Try to regenerate the activities that's there and restore function. That's what it stands for. And again, this just gets at the idea that clinical care, you start with the person and you work your way down to wanting to sort of get the diagnosis and then institute treatment. Research does the opposite, which is we start with a hypothesis, and then we start to do our research, and we ultimately want to get back to the patient. And this is, when you do what we do at Hopkins, we believe this is the best way to sort of get communication back and forth, which is we have people who know what it is to need to diagnose people and know what it is to have patients who need our help and not have enough treatments available to us sometimes to stop the inflammation or restore the function. And so it takes on an urgency because it's not just a theoretical thing. It's our patients, it's the people we care about and want to help. So this is what it's about, and it sort of says Project Restore, restoring hope, function, and lives to patients with MS and TM. And that's sort of the goal. So again, what we want is a medical revolution. We want to offer the best care available and develop these kinds of things that we talked about. So you can jump in any time, by the way, if there's something you want to say. But let me just finish the section on the Project Restore, which is, so how do these things get done? How do we do the research that I'm about to sort of give you some of the highlights of? And the answer to that is 4 main sources of funding that we get. Traditionally, we apply to NIH. NIH gives us grants. The National Institute of Health gives grants. Those grants actually have indirect costs associated with them. So for every dollar we get, there's some additional cents on that dollar, more cents than you might imagine in some institutions and less in others. But it's sort of the money it costs to keep the lights on and the institute functioning. So that's large center grants, often 500,000, million, or multiple, sometimes $1 million, couple $1 million over several years. These are getting harder and harder to get. And in fact, right now, it was 10% is the funding rate at NIH now, before the sequestration. So before the sequestration that everybody's heard about, it means that 9 out of 10 of our ideas that get scored, sort of think of it as us getting anything below an A is a fail, okay? So if you don't get above 90, you don't get any money. It's not like, oh, well, I got a B, so I passed. If you're not in the top 10%, and that's before the sequestration, so that means 9 out of 10 of our ideas don't work. More importantly, because they're only funding 10%, this is the same problem with the pharmaceutical industry too. Because they're only funding, they have limited funds, the things that they fund, they want to fund things that are really a high probability of working. So the grants that are getting funded are the grants that are basically either building on known accomplishments where they're just extending, it's not a breakthrough, it's just extending something that we know is already working. It's not the Hail Mary kind of set of, thinking outside the box, coming up with new treatments. And they also want us to already show them effectively when we apply that it worked in a small scale. And now we just want the money to do it in large scale. And of course, you need money to do the small scale to show that so you can get the large scale funding. So that's where we are with NIH. And it's essentially a mess. It's so much a mess, just to give you an idea, that my my colleague, who was my postdoc and now is a junior faculty member, wanted to apply to the National Institute of Neurological Diseases to pursue research in MS. And they don't even have a grant anymore. They've stopped their grants, their training grants, what are called K grants, in the National Institute of Neurological Diseases. So you can't even get a grant if you're a young faculty member and you want to pursue research in MS. Isn't that unbelievable? So you have to get it from somewhere else. So where are the other places? Well, industry. And so we are doing some pilot studies, working with pharmaceutical companies that have drugs, those drugs they want us to try out and see if we can, extend their work and see if we can try it out in our patient populations and the like. The problem with that is, just before I say this, how many people work in the pharmaceutical industry right now? Okay, so the problem right now is that the pharmaceutical industry is in huge trouble. And let me tell you why. So Lipitor, how many people have heard of Lipitor? Everybody's heard of Lipitor because it was a $10 billion a year drug that became generic and now is a no billion dollar a year drug for the company that made it. And so here's the problem. If you had a $10 billion a year drug and suddenly it goes from $10 billion to like nothing, you have to make up $10 billion somewhere else. And if you don't have the next Lipitor, which they don't, then if your revenues go down and you want your stock to stay where it is based on, the still coming in, still have the money on the ledgers be the same, you have to decrease your costs. So you're bringing in less money, so you have to spend less money to have the same amount in the bank so that the stock looks good. The problem is that extra money that you stop spending, AstraZeneca has completely wiped out all its research on neuroscience. Pfizer has cut its neuroscience budget by 60%. So essentially, it's sort of like saying we're running out of oil and we're stopping drilling for more oil because we don't have the money to drill for oil because it's going to make our stock go down. So they're in big trouble. And so the pharmaceutical industry is really having a hard time too. And I keep seeming to hit the wrong button here. So foundation gifts, and those are still a source. There's the Michael J. Fox for Parkinson's disease, so the National MS Society provides grants. Thank heaven they provide grants, because I just got one. So it keeps, keeps the lights on for some of the research I'll show you. So that's good, but again, these are private foundations and sort of very competitive, like the NIH is, but thank God they're there. And then there's philanthropic gifts. So we're going to pass a hat around. No, I'm just kidding. So, but I will tell you, those philanthropic gifts nowadays are more important than they ever were because we can take what is a relatively small amount of money, invested in doing those pilot studies, and then go to the NIH and say, see, it works. Now we can get leverage to get the higher amounts of money. But essentially to do those Hail Mary passes and the next kind of thing, what the message is here is that if this doesn't take up the slack, then these other three these other three have gone down, then research is just going to sort of grind slowly to a slower speed because this is just where we are. Now, it's hard out there. Everybody's having a hard time. Lots of people have lost their jobs. I'm not trying to say it isn't a hard time for everybody, but it's just something worth knowing. So again, the research that we can do, early stage research, leverage other funds. And it also, in order to have a social worker or a nurse in the clinic to take care of the phone calls when the patients come in and those kinds of things, and to sort of design a multidisciplinary center where people are coordinating together. There's no money that's paid for me to talk to the neurologist and say, here's what I'm worried about. Your steroids make the patient manic. Right now, their mood isn't stable, so we have to talk to each other about what the best treatment is. There's no payment for that. That's time that we invest because we care about our patients, but no one is paying for that time. And so again, a lot of times people are trying to get funding for their centers so that they can hire the staff that we need in order to do it, because the insurance company will pay for me to see the patient, but they won't pay for me to talk to someone else, and they won't pay for a nurse to be there when I see the patient. So did I give a good overview of Project Restore? Is this the...
You did.
Did you want to say anything about Project Restore before I go on and show some of the examples of what we've done with leveraging some of the gifts that we've gotten?
Yeah, I think I would just reiterate, I'm actually involved with Project Restore, and how I became involved. I was diagnosed with MS back in 2007. And what I experienced at Hopkins was a collaborative effort between the physicians, and they really do care about the patients. They care about the research, the patient care, and it was just so overwhelming to me. They took me from a very negative time in my life to where I am now. And, you know, MS is not an easy disease. You know, it comes at you in many different ways. But for me, being the grateful patient, that's what keeps me going, is to do philanthropic work. And to say what Dr. Kaplin had said about, you know, private philanthropic work, it's more important now than ever. And so, you know, I just try to advocate that as well, because the work they do there is just phenomenal. So, thank you.
Thank you. So now I have to, you know, live up to the phenomenal part. So in the interest of time, I'm going to just give you a potpourri, sort of a bouillabaisse of research here, just to hit some of the high points of a lot of the things that we've done as a result of leveraging what we have. So this is, believe it or not, a picture in the Cayman Islands of a research project. Isn't that a great research project? So this right here is me, okay? And I got a call from Cody Unser who said, look, I'll tell you, you know, so Cody's foundation wants to educate people. They want to have, you know, do stem cell research. That's, you know, that's her main research interest, and quality of life. And her quality of life thing is to get people who are paralyzed. Even quadriplegics can go with her and do scuba diving. And remember, water is pretty terrifying to people when they're paraplegic because they think they're going to drown, but you don't drown when you can breathe an underwater breather apparatus. And it turns out she swims circles around me in the water because she's, you know, it's you know, the same thing using her webbed gloves as it is me just paddling my fins. And so, but she said, look, Adam, I have something that happens under there. Under the water, I get these sensations that I haven't had. And I said, yeah, Cody, I'm sure that you do, but I mean, are you drinking beforehand? Or no, she said, no, really, I get these sensations. So I said, okay. I said, well, we'll do a study. And we got, philanthropically, Bruce Downey gave us $25,000, and we raised the rest in-kind gifts. And we took these paralyzed veterans. The paralyzed veterans are the ones without fins, because they have to tie their feet together so they don't sort of float apart, and then they scuba dive. And we went there, and they did 10 underwater dives in order to get certified. And Cody said, if we went, me and Daniel Becker, the neurologist who went with me, she said, you guys have to learn what this is about, because you don't understand anything about scuba diving. I'd never been scuba diving, so you have to go to understand it. So the first thing we found out, so we tested all these 10 people who were paraplegic from war injuries and 10 able-bodied friends that went with them, so we had a comparison group. And we tested them before, on the first day in the Cayman Islands. I know it was terrible, we had to go to the Cayman Islands. And then 4 days of doing 10 dives to get certified, and then on the last day, so it's 1 + 4 is 5, and on the 6th day, we retested everybody to see what had happened. And so I did the sort of psychological testing, and I know it's not going to come as a shock that people's moods went up. That's not going to be a huge shock. But this was sort of surprising, which is those subjects that had had PTSD symptoms, which, as you know, with war is a major problem, their symptoms resolved up to 100%, and on average 80%. So that's really unusual because, you know, people who have post-traumatic stress disorder, where they have these re-experiencing phenomenon and they have repetitive dreams and they are startled, even if you take them to the beach, it doesn't matter because they bring that with them. So this was sort of pretty interesting. But what was really a shocker is my pager started going off when I got home because we did this study. Then we went home and Daniel took all of the data with him on the neurologic stuff. And he had to look at it and see was there a difference before and after. And my pager started going off and I was like, what, Daniel, what? And I called him back and he said, there's something going on. Cody's right, there's something going on. So we looked and this just shows you that the spasticity, which is, when people have strokes, they often sort of look like this. They're contracted because not only does the brain cause something to move, but it also causes it to relax. And so spasticity is the pain that people get when they can't relax their muscles. And it really helped with spasticity a lot, 16%, which is unusual because, as Kristen can tell you, because she's an exercise scientist, normally with exercise, spasticity gets worse. So that was sort of interesting. But what was also interesting is up to 20% improvement in almost all of the subjects in either light touch or pinprick. People who hadn't felt anything on an average of 15 years were getting sensations that they hadn't had. And 4 out of these people actually had regaining some ability to move their legs that they didn't have before. And one guy, you just said this is the first time he could actually stand up enough that with his upper extremities, he could get himself to his seat without having to be taken in a wheelchair down the aisle. And that was pretty amazing. By the way, just so you know, this group out here, you say, well, why? He's sort of hiding these people, and they didn't have any benefit. It turned out that 2 of the people who went scuba diving, these war veterans, one had inner ear problems, so he couldn't tolerate it. The other one ended up having a phobia about breathing underwater. And they ended up being good controls, because those were the 2 who didn't have any benefit. So, that was sort of amazing. And when we thought about how is this even possible, we went back to the literature, and we realized something, which is that scuba had been known for a long time to cause, this is why you have to get certified, because you learn about nitrogen and how nitrogen can cause narcosis. It can make you sort of go, oh, pretty fish, and you take off your mask and you swim after it. Okay, so you have to be very careful about that. But it gets you sort of high. And so when we looked at the literature as to what it does to the spinal cord, what was interesting is it leads to this huge 350% increase in serotonin. And I'm just going to quickly tell you, and you'll have to take my word for it because I don't have time to go through the detail, but if you cut the head off a chicken, that chicken's body keeps running. And the reason why it keeps running and the reason why you can walk and chew gum at the same time is because walking takes place here. This is where the circuitry for walking is. And it turns out all of this circuitry in the spine, you can either stimulate with a stimulator, which Kyle's going to do when he's telling me about his electrical stimulator, and he's going to be an orthopedic god, right, Kyle? Yes. But so people have done this now using stimulators. We believe that we just got into the same pathway using serotonin, and I can't give a drug that increases serotonin 350% right now, but now we are going back to the lab, and we're taking mice, or rats actually, and that have spinal cord injury. They all volunteer for this, I swear. So, and then we're giving them serotonin right into their spine and see, because people can put pumps in. You might have heard of baclofen pumps or opiate pumps, and putting pumps into people's spine is actually not that hard, but no one's thought to put serotonin in. So there you go. $25,000, maybe it turns out that you can reactivate the nervous system using the existing circuitry, and you don't need to use stem cells from outside the body. This isn't G. Maybe one day we'll figure out how to get the stem cells working. This is G. Right now, we can get people beginning to regain function after 4 days. So let me just tell you real quick. Depression is a terrible disease. It accompanies MS. MS is the highest rate of depression. Diagnosis of depression is you have to have 5 of 9 symptoms for greater than 2 weeks, and that's trouble sleeping, decreased interest, people's get up and go has gotten up and gone. They have guilt or worthlessness, which is also what makes it hard for them to go get help because they don't want to burden anybody. They have low energy or fatigue, the low mood, but that's just one symptom. You don't have to be sad to have depression. You need to have a constellation of symptoms. Concentration problems, appetite changes, what's called psychomotor retardation, which is you're not the normal bubbly self that you are, however bubbly you normally are, and then thoughts of death. Here's the bad news. Bad news is I advance it one too fast. So here's the bad news. The bad news is that you know, if you look at over the last 50 years, how have we done treating various kinds of conditions? We've done pretty well at decreasing the years of life lost due to malignant neoplasms, cancer, and heart disease, and that kind of stuff. But the red line shows you that in the last 50 years, we've made no headway. If you start here, it will start to get a little better there, and you get here, no benefit. People are still killing themselves at the same rate they did 50 years ago. How is that possible? We've got all these medicines now. And it's even worse because this is out of the Lancet recently. Back in 2007, the adults here know the bottom dropped out of your stock market portfolio. And so there was this increase of, not only is it not getting better, it's getting worse. You know, you might have read about the military, #1 cause of death in the military is not getting shot over in Afghanistan, it's suicide over in Afghanistan or in this country. And it accelerated, this increase accelerated in the general population with the downturn in the stock market such that suicide went, you know, you can't please everybody all the time. So suicide went, it's now become the second leading cause of death in the 10 to 14 range. I mean, luckily babies aren't crawling off coffee tables, but once you get to be 10 years old, that's when the suicide rates and depression onset starts. And because of these increase in suicide, suicide has gone since 2007 to become the top 10 reasons for people to die. And so why do I study MS? Just like Willie Sutton. Why did Willie Sutton rob banks? That's where the money is. I study MS because that's where the depression is. And I'm not going to go into the detail except to tell you that MS causes the depression. It's not a personal weakness. It's not, gee, you'd be depressed too, because it doesn't matter whether or not you're upright and mobile or whether you're, you know, in a wheelchair. What matters is if you have inflammation going on in your central nervous system. So that's what it's really about, and we're trying to understand that better. This says, of course, your daddy loves you. He's on Prozac. He loves everybody. So the fact of the matter is that we do know these drugs work, but we also know that we're not doing as good a job as we need to try to fix this. But what's interesting, and this is something to just have on your radar, because this is true if your, God forbid, grandmother has a stroke, or if she has a traumatic brain injury, or she has MS. This shows that in those people who were not depressed and put on Prozac, compared to those people who were put on placebo, those people who put on Prozac were much less likely to get new lesions in their brain. And I could show you another study that showed that people who have had strokes have better recovery of their function if they have an SSRI. So it turns out the drugs that we use, so if I told you that inflammation from these systems caused the depression, then if inflammation causes depression, is it so dramatically impossible to imagine that the drugs that we use to treat depression would actually help the inflammation? I mean, it actually turns out that that's the case, that these things are working together. And how many people know lithium? Have you ever heard of lithium? Yeah, so lithium used to be in a soda. It's not Coke, because Coke had cocaine. We all know that, okay? So lithium was in a soda. Anybody know what soda lithium was in? Wow, that's pretty good. 7-Up. So there it is, lithiated lemon soda, fresh up, keeps smiling. These are the actual things. And that was great until you got toxic and your kidneys failed because you weren't monitoring your lithium level, just like it was great in Coca-Cola until you got addicted to cocaine. But the bottom line is that we now know that lithium in every animal model that we've tested it in is really good at protecting neurons. Remember, we don't have a good way of protecting neurons. And there was a study that came out last year that showed a delayed progression to Alzheimer's disease. We are now testing this out in MS to try to see what's going on. So I'm just going to go through this really quickly. Gee, wouldn't it be great if you could just look at someone's MRI and say, you're depressed and we know why? And it would be great if you could look at the MRI. These are the actual lesions in a patient who had MS. And you can see these are the areas where these white fluffy parts, that's where the inflammation has happened in the past. And so that's where the attack took place. However, I could show you this picture of this person as I am, and you wouldn't be sure if this was me or if this was someone who was very disabled. You couldn't tell. It doesn't correlate. So we had to come up with a way to understand better what's going on. And so we really wanted to see what's going on with the depression in the brain. And so we did a study where rather than look at the structure, we looked at the chemistry. You can actually use the same magnets, an MRI machine, and look at the chemistry in the brain. And for all of you geeks out there, that's called MRS, magnetic resonance spectroscopy, which is the same thing you orgo people know is NMR, nuclear magnetic magnetic resonance. Why didn't we just call the MRI machine a nuclear magnetic resonance machine? Because who wants to get into a nuclear machine, right? Nobody. But that's what it is. That's essentially what it is. And what we saw is, we saw that there's a nice correlation between, number one, those patients who were depressed, we could actually get a readout. You could see that their depression went up as in their hippocampus, certain chemical changes. We could see these changes in their brain that correlated with their depression. And we could see the changes that correlated with their ability to remember and learn things. So that's great. And it turned out that this level of the NAG is a neuropeptide in the brain. It's a signaling molecule. And it turns out there's a drug that's never been used in humans, but it prevents the enzyme that chews up NAG, which means it increases the NAG levels, which means it should take people and improve their performance, their memory and concentration. Problem is you can't just give drugs that have never been used in people to people. So what we did was we gave these drugs to mice that had the animal model of MS. And let me just tell you, in the first day, the group that got the drug versus the group that just got sugar pills, there was no difference the first to the second day in learning this maze. In the first to the third day, no difference, but you could see by the fourth day, the group that was getting the drug was dramatically better at learning. In fact, they were over 225% better. And how much better is that? Well, it turns out it's a lot better. It's so much better that this is the group here of the animals. See how they go from here to here, which means from day 4 to day 1, they forgot their way through the maze. Just take my word for it. But you can see here that the animals in blue are the ones that got the drug. They didn't forget. And the animals in black were the ones that didn't have MS. So the drug got the animals that had MS just as good at running the maze as the animals that didn't have MS. That's like the holy grail to be able to improve cognition all the way back up. Now, here's the good news too. It turns out Alzheimer's disease have a decrease in the level of this same thing, NAG, in the brain. Now we can begin to test this in animal models of MS, of Alzheimer's disease. And if we had the funding, which we're applying for to NIH, and we're applying for to these various things, but it's hard to come by, we might be able to come up with something of interest. So I think just in the interest of time, I'm going to skip through how we basically were able to show we could prevent suicides using, using antidepressants. I'm just going to skip that in the interest of time. But happy to talk about it later if anybody's interested. Here's the good news. If we really cared about depression, this shows you, and I talked to some of you earlier, some of the students, that you can see here when the Henry Ford Medical Group in Detroit actually applied a comprehensive care system to try to help patients who were depressed. They took the suicide rate in that clinic from 90 per 100,000 to the last 3 years, 0 per 100,000. So it's not that we don't know how to treat depression, and it's not that we don't know how to deliver good care. It's that we don't have good model systems, and we don't have enough research going into showing us how to develop these systems. One of the things that this program did was have a way of monitoring people's moods. And it's hard to see here, but this is basically, this is the Mood 247, and this is a real patient, a young woman who just had dropped out of college because she was so depressed, and this is what it looks like to get better from depression. I put her on, in this case, Lexapro, and she got better. It's hard to see, but she was still having changes in her mood with her menstrual cycle, and that I recommended that she then go on to Seasonale, which makes it so she doesn't have her menstrual cycle every month. It's every 3 or 4 months. And I recommended that, and I could write that right into her mood chart, which is online, and she gets sent that text, and she could share it with her OBGYN, who then put her on that. And now she's back at school and doing great. So, this is basically a simple technology. You just get a text once a day on a scale of 1 to 10 as your mood, and it goes into the online chart, and I can see it, and she can see it. And so this is the drive towards complex technical achievements offers a clue to why the US is good at space gadgetry and bad at slum problems, right? This is simple gadgetry. This is a text sent to someone's cell phone once a day. Last thing, I'm just going to close with it is, turns out if there is a way to take someone's immune system and wipe out their existing cells, take their immune cells down to 0, and let their bone marrow replenish their entire supply of supply of new cells. And this is actually a study we did at Johns Hopkins where we took these patients, and the normal white blood cell count is 5 to 10,000, and we gave them very high doses of a drug called cyclophosphamide. Their white blood cell count went down to close to 0, and then 2 weeks it popped back up again. And what was really fascinating is these patients, not only did they shut down their MS, but they regained 40% of the function that they'd lost. That meant one of the guys who needed a walker to assist him walking can now run and jogs every day. So, and this just sort of shows you the outcome. These patients were getting worse and worse, as you can see, for the 3 years before they got treated. Then they got treated, and this guy is the one who went all the way back down to 0 disability. So we know we can actually reset the immune system. These are people who are desperately in need of something to shut down their immune system. This is heavy duty. They lost their hair. They had no immune system for 2 weeks. But we now have done this and added Copaxone onto this and showed that we can take another 30 patients, and 80% of them at 2 years had absolutely no evidence of their MS. No new lesions, no loss of function. So the bottom line is Hans Berger is actually the guy who invented the EEG. Somehow EEGs are very popular here at Elon. I was talking to a bunch of students who are all doing EEG studies. I don't know what it's like in the water or something. But it turns out Hans Berger is a psychiatrist. And he invented the EEG because if you had epilepsy, you were considered insane and put in an insane institute. And he said, you know, some of these people, they don't seem like the others. Like when they're not having a seizure, they seem perfectly fine. And there seems to be something going on. So he hooked up this EEG. And what I'd like to say is that as we get better at diagnosing depression and using things like MS and better treating MS and visualizing cognitive impairment and visualizing depression, we maybe take epilepsy, which is now not considered a psychiatric illness, it's considered a biologically based disease, and changing depression into the same kind of thing so people understand it. So just last slide, what we want to do is move from the focus on disease, which we're beginning to do, to now trying to understand better how we can help to create, to focusing on creating health. Not just shut down MS, but start to restore function and have this spill over into other kinds of conditions. So according to my clock, because I have a clock here, that took 55 minutes, and I think I've got time for questions for 5 minutes. If anybody has a question, and thank you for your, I'm getting the sign like, many questions as you want. So thanks for your time and attention. Yes.
Well, some telling me not to, but I'm going to ask anyway.
Go for it. Don't listen to her.
You were talking about the people that you didn't study that you wiped out their immune system.
Yes.
And then some of them had none. Why is it that you can't do this for anyone that has MS?
So it's a great question, and what I can tell you is that, and here's the bummer, we can do this for anyone that has MS. And when we did those 32 patients and showed that the Copaxone prevented the reactivation, that was key, because that first 9 patients, 80% of them reactivated by 2 years. And if you're going to lose all your hair and go through this, although they were doing well for the first 2 years, then they reactivated. They didn't get worse. They just sort of reset the clock and started going back up. When we gave them Copaxone, they didn't get worse. And so you'd say, well, great, we're ready for the large study to do it. And we are ready for the large study. The problem is the large study will cost $1 million. And Kristen, do you have $1 million by any chance on you? No? So giveaway. Yeah, it's a giveaway. So we went to NIH, and NIH said, $1 million is too much for us. Go to the pharmaceutical companies. So we actually flew to Israel to talk to the company that makes Copaxone. And we said, look, you might be able to cure MS. I mean, put people into remission where they'll never have another symptom. And they said, yeah, but we already have this drug Copaxone. And it's going off patent, like Lipitor was going off patent. So we don't want to really put $1 million in because someone else could start making Copaxone, and we won't get our money back. So the problem is that we're continuing to do this on exceptionally bad cases and exceptionally bad situations for people, but we don't have, this is just the reality. Some people, and I'm not one of them, I do know that some people say, well, of course the pharmaceutical company doesn't want to do this because if you cure MS, then you're not going to have the $50,000 a year for the MS therapy. I don't think it's quite that simple. I think that still these companies would like to cure MS, but these are using older drugs in new ways, and that's harder to sort of protect. Like Percocet is an opiate and Tylenol, and that's together, but sort of adding things together has been done, but it's harder to do. It's a good question, but it's, yeah.
Would you have to set like an age limit on that because, as people get older, their thymus is going to get smaller, so they're not going to have the location for the maturation of their T cells?
Well, aren't we the immunologists? Yes, that's absolutely true. No. Oh, see, there's a ringer. There's always a ringer in the audience. Yes, so that's a really good question. I will tell you that it turns out that the thymus is really important when you're younger. And then as you get older, you can actually do okay without the thymus. People with myasthenia gravis, you remove the thymus, actually, is one of the treatments for myasthenia gravis. But you're asking a great question, which is I'd be remiss if I said, gee, we'd have to do the study. And I'd like to do the study, and I think you're absolutely right. I think that there would be an optimal age. That guy who got all the way well was actually the youngest person in the study. He was in his early 20s. So just based on that, I'd say you're a genius, and you should come work with us, and you're right. And yeah, that's probably the case. But it doesn't mean that it didn't work for the older people. It just meant that they had, not a complete response. They got 40% better down, from a, 4 to a 2, or 5, or 4 to.
It wouldn't work. They just might be compromised.
So it's a very good question. And the answer is yes, you do have to worry about down the road because you wiped out the immune system. In fact, we have to re-immunize people. We have to give them measles, mumps, and rubella all over again because you've reset their whole immune system. But it turns out, they've been doing this treatment for aplastic anemia for over 15 years, and no one's gotten compromised immune system. If people die, they died because the aplastic anemia came back. Yes, Ms. Smith.
So is this treatment done for more primary progressive, any relapse remitting?
So this has been done, and again, it's a great question. This has been done only for relapsing remitting that we've done it. Now, some other groups have done primary progressive because again, Melinda's a ringer. As Melinda knows, there's no treatments that are approved for primary progressive. And I can just tell you that the jury's out as to whether that would work. I think what happens is, I think that if you stopped inflammation, then some of these other drugs like Copaxone and maybe lithium and SSRIs, and there's other drugs out there that are believed to have neuroprotective effects. I think that they could start working if you shut down if you turn the fire down, then the fire crew could get in and start building stuff back up again. So I think it would work for progressive MS if you reset the immune system. And then gave them neuroprotective agents, but I have no data to suggest that. I think it's a good idea, though. Yes?
The relationship between NAAG and Alzheimer's, is that something that's been looked at before? Is that entirely new?
No, so that's a very good question. And that study was, I think I'd have to go back and look at it. It was like ancient. It was like the 90s, okay? Those of us, many of us think that's funny because that's not so ancient. But to you guys, that's ancient, like early internet years. So it was an observation that was made that they had lower NAAG levels in the hippocampus, and they had no idea what to make of that. And our group is the first group to go, and we went to humans first and did the brain scans and found out that the NAAG levels correlated with cognition and memory. And then we went back and looked at the literature and found that this same low level of NAG was also seen in Alzheimer's disease. But back then, there wasn't a drug that you could use even in an animal model to see if it works. So you can find lots of things that correlate, with various things, but correlations don't show you, if correlations were all you looked at and you were looking through a big telescope at the Earth, you'd think that people rode around in these cars with red lights on them and hurt people, because every time someone's hurt, there's a ambulance there, shows that they're correlating with hurting them, but actually they're there to help them. So you don't know if the NAG levels go down to try to help or, so it's just an observation that was made a while ago. But now that we understand in MS, we think, gee, isn't this interesting that they have low NAG levels just like MS patients? And if we increase them, maybe we would have a way of changing that, because as you guys may or may not know, nothing has worked as a approved treatment for Alzheimer's disease. Meaning nothing has worked that changes things more than a couple of months. So Aricept and Namenda and stuff, they take people on this sort of 10-year sort of trend down, and they add 2 or 3 months. It's so little that in Europe they don't use those drugs because they just say really 2 or 3 months in 10-year phase. So we don't have anything that really does stop Alzheimer's in its tracks. And so it's a huge need because baby boomers are getting up there, and you guys are all going to be taking care of us in our old age, and you're going to want to get many of us better so you don't have to take care of as many people. Yeah.
You hear a lot about MS, but not so much about transverse myelitis. But I was just wondering if you had like any statistics in like the frequency of those diseases.
Yeah, so we do. We do have frequencies, although I will tell you, it is hard to get a head count, especially with transverse myelitis because, and it's a great question, I appreciate you asking it. From what our head count says, it's 1/10 as common. So MS is probably in 1 in 500 women, 1 in 1,000 men in this country are affected. But having said that, it's the second leading cause of disability in young adults, of neurological disability, because 20 to 40-year-olds aren't having strokes, luckily, very often and stuff. So, it's not that it's rare, but TM, transverse myelitis, is 1/10 as common as MS, so it's even rarer. The reason why it's hard to know if that's truly the case is transverse myelitis, 1/3 of the people, it follows the law of thirds, 1/3 of the people when they get TM get all the way better. And those are the, old guys who just like, it's nothing, I'll just sleep it off. And they do. They sleep it off and they get better and they never go to the hospital. And 1/3 of the people will sort of have some chronic kind of weakness, but they'll recover some function. And then 1/3 of people are like Cody Unser, and they have complete loss of their function below that level. So, obviously the people who do better, we don't count because we don't see them. It's hard enough to get it diagnosed. But so it's definitely rare. It's definitely something we understand less about. That Scuba study was done by the Cody Unser for Steph Foundation, which is a transverse myelitis foundation. And, one of the more exciting things we do is, and Melinda is going to help me make this dream a reality, is we're going to go to a Paul Newman hole-in-the-wall gang camp in England because these kids have never met another kid with TM. And we're going to go there and we're going to teach the parents who have never talked to an expert in TM, because the only centers in the world are at Hopkins, the first center, and UT Southwestern, the second center. And so we're trying to go over, right? We're going to get there. Go over to one of these Paul Newman over-the-wall gang camps in Europe and have the families come in. And we're already talking to them because getting people together with these rare diseases is just an incredible thing to say, oh my God, you know what I've been through.
Kind of a secondary question on that.
Let's take a vote. How many people? Secondary? Yeah, okay. We're good. We're good.
So you mentioned like it's much rare, or it's about twice as common in women. Is there also a difference in like, what is it? Is it more difficult on women?
So it's actually, interestingly, it's worse in men. It's half as common in women, but overall it causes more disability in men. And whites compared to blacks, it's similarly taken on as a whole, it's half as common in the African American population and twice as aggressive, and it has a higher genetic association in African American populations. So we are beginning to understand the genetic causes, but we're also beginning to understand vitamin D is a big deal. Anybody who's got MS, don't raise your hands. You really want to make sure your vitamin D levels are, normal is above 30. We like patients 50 at least, maybe 50 to 75, because low vitamin D we know leads to an overactive immune system. And of course, it's easy to say, African Americans have a harder time getting adequate vitamin D levels. So that may be partly why. But there's also genetic contributions as well. So what I tell people with MS is they say, gee, there's maybe a 5% chance, 2% chance, or less that, my Aunt Tilda had it. What can I do to try to make, small fraction of a chance, but better, higher than the general population? I say check your vitamin D. As best we know that's going to be protective. You can't change your genes. That's that 30%. But you can work on that 70%, which is the environment. One of the interesting hypotheses, by the way, is that you know how your mom used to chase you around with the Purell every time you touched something that was maybe dirty? So it turns out that one of the hypotheses is that there's the hygiene hypothesis, that we do know the rates are going up. The rates of MS are going up, and the rates of a number of autoimmune diseases are going up. We've got very good data to suggest that. And one of the hypotheses is that we're all using SPF 1,000,000 now. That's partly it. But another idea is that it turns out if you get Epstein-Barr virus infection before the age of 15, your chances of getting MS go way down. That's the mononucleosis, but it just causes, many people get it without getting the full mono. And it's like chicken pox. If you get chicken pox when you're an adult, your immune system gets way more aggressive than if you're a kid. It's like, oh, you get some pox, no big deal. You're an adult, you get chicken pox, you get wiped out. You can get very, very sick. And so the younger immune system learns to tolerate. And you can ask this bright woman about the tolerance of the young immune system. And so probably part of it is that, my grandmother used to say you have to eat a pound of dirt before you die, just not all at once. And so probably is some truth to that, we maybe are too clean. And, we grew up with all our kids, together on the savannah, swapping spit and all that. And now we have kids off in a sterile environment. So I think we're getting towards the end.
When you wipe out the immune system as a form of treatment, I was just wondering if you knew the mechanism for gaining more function back, if that can be used for other autoimmune.
Yeah, see, don't they ask great questions? Don't they? So that's a great question, and I believe, and I don't have data to prove it because we've only done, the first 9. We studied very closely because we had a $200,000 grant to study those first 9, and we did that study where we got MRIs. The next 32 patients, we didn't have nearly as much, so we did the best we could, but we didn't have the ability to draw their blood and do all of this stuff and get regular MRIs on every one of them and every 3 months. So, but as best we could tell, and my best guess is that, we know that in a site where the immune system attacks the brain and strips that insulation off those wires, if you look in people later on with MS after they've died, luckily MS doesn't really decrease people's lifespans. But when you look later on, you can see that the myelinating cells, the cells that rush in and put new insulation on those wires, they rush to that scene and they get there and they stop. And they don't do anything else. And probably if you shut off the inflammation, maybe they reactivate. Maybe it's the inflammation that says, stop. And if you really got rid of those, chemical messengers floating around, that those immune cells, I almost doused my Macintosh with water. That's bad. So maybe if you stop the inflammation, you could really then start doing some repair. And this is where things are going. We now have better treatments than we've ever had. So this is pretty heroic. But there are treatments out there like Tysabri, which blocks the ability of the immune system. It coats an antibody that coats white blood cells. It's an infusion once a week, and it basically binds to VLA4, which is the intracellular adhesion protein that is the key that the immune cells use to unlock their way across the blood vessel into the brain. And lo and behold, people are now seeing that people on Tysabri, some of them, actually a number of them, are starting to regain some function that they'd lost. And that's great. it does have a 1 in 1,000 chance of death as a side effect, and that's a bad side effect. But we're getting better at knowing which 1 in 1,000. So it turns out we now have a blood test that says if it's this JC virus, it's a particular virus that if it gets going in your brain, those immune cells can't get in and fight it off. So if you're JC virus negative, you don't get this terrible side effect. But what's interesting about MS is it's bad enough that when this drug was pulled off the market in 2005 because we realized 1 in 1,000 people were getting this brain infection that led to coma and death sometimes, the patient said, wait a minute, our drugs are not nearly as good as that drug, and I'll take my chances 1 in 1,000 if it means I'm not going to just lose function. So, you know, the times are changing as to what's considered an acceptable side effect. And now, it's interesting though that everybody was really interested in the curing MS. Curing MS, sure, that's interesting. But saving lives from depression, that's really cool. Restoring cognition. Now, we'd all like to do this, but these are the kinds of things, and I'm only scratching the surface. These are sort of, I could have been Peter or Carlos and come in and shown you that now people can look through the eye using this radar system called OCT, and just looking at the back of the eye, see the blood, the neurons in the back of the eye, and tell you what's going on in your brain based on those neurons. So these scans that can be done in the office and the like, and you know, turns out there are certain drugs that that Peter's working on that activate those oligodendrocytes and trying to figure out what to do to activate them even in the presence of inflammation. So there's a lot of stuff going on, and you should definitely all go into science and all do research and all take care of patients, but realize that it's an exciting time. I mean, this was science fiction just, you know, 5 years ago. The idea of resetting the immune system for MS was science fiction. The idea 5 years ago of looking into the brain and seeing depression or seeing cognitive impairment or being able to reverse the effects of learning and memory problems in MS, that was science fiction. So it's a very exciting time, but you got to do what you love because there are going to be lean times where the money's not there, but I do believe it will come back. The economy's going to eventually get its way back, and thank you for your time and attention. So.